Now we have to move on and talk about Impella support for patients with pulmonary congestion and cardiogenic shock by Ralf Westenfeld from Düsseldorf.
Okay. Yeah, ladies and gentlemen, thank you very much for the invitation here. Being on this W hotel is a little bit like being on outer space, at least when you look in the Mediterranean. And so I'd like to bring you to the solar system of cardiogenic shock. And most of us are cardiologists or cardiovascular surgeons, and therefore it is critical and understandable that we put the heart in the center of our ambitions. Previous speakers alluded to the fact what we can measure in terms of our pressures in the heart and in terms of outcome. Looking as an intensivist, we already know that there are certain other planets that we have to take into account, just if you think of Apache scores, and that will tell you about the outcome. And within the next few minutes, I would love to show you that it may make sense to look a little bit closer on the lung and to allude whether you can tell something if you have high water in your pulmonaries, like pulmonary congestion, in terms of your cardiogenic shock and the mode of mechanical circulatory support that you would love to apply to your patient. So, yeah, pulmonary congestion, cardiogenic shock, you have to search a little bit to find it in these areas where they say, well, it may affect post-cardiac arrest syndrome and outcome in our patients that we're treating every day. There are some papers telling us that it is an unrecognized problem in patients that we transfer from VA ECMO to an LVAD, and that is associated with improper outcome. And we have checked that, especially in a highly selected cohort of VA ECMO patients, that increasing pulmonary congestion within early 24 hours is associated with improper outcome. And if you look at the usual suspects, increase in pulmonary congestion on VA ECMO is as bad as having dialysis at any time point down the line. And we all know that these guys are really, really in bad shape. But there are basically no studies comparing or looking at pulmonary congestion and cardiogenic shock apart from ECLS. So in the start, our hypothesis was that pulmonary congestion and cardiogenic shock develops differently according to mechanical circulatory support. And here, I like to present data on Impella versus IBP. And second, early increase of pulmonary congestion also in this cohort may be associated with adverse outcome. Well, one thing we had to use is a very, very easy and old method how to quantify pulmonary congestion without any CT scanner. You can't go there every day. And so we just looked blinded fashion at the chest x-rays, and we tried to sum up 6 areas, and so we could come up with a severe congestion, meaning a Halperin score of 310. You could go to moderate congestion around 200, and you could go to mild congestion at 100. So you have numbers, and you can do some math around it. We, of course, had to start with a retrospective design. We went back to the year 2012, that at that time usually using the IBP. We had a small area where we used both systems, and currently we just, like most of you may have done it, thrown out the IBP from our cath lab. And so we came up with 74 patients with cardiogenic shock and MCS treatment of these 2 devices. We lost one in the early period, and of course we had to have, through x-rays, 2 x-rays, I introduced some kind of a blanking period so that I came up with 30 versus 30 patients on IBP or Impella treatment in cardiogenic shock that I could arrange and analyze for sequential chest x-rays. So these are the patient characteristics. They're reasonably similar. There are, like in the earlier platforms, quite sick, CPR in almost half the patients, STEMI and revascularization. They have a fairly sick SOFR and Apache score. And these are some clinical characteristics where I try to just for eyeballing. We had fairly high serum lactate on implementation. We had even higher lactate levels on this Impella treatment. We had fairly high troponin levels ranging around 5,000, no significant differences there. We had a high inotropic score, a little bit, a tendency even higher in the Impella group. And these were LDH levels. We had some hemolysis, of course, in the Impella group, but no difference in hemoglobin, so this was not clinical significant. So Impella was associated with some hemolysis, and at least one can discuss whether the Impella group was a little bit sicker or whether there was better perfusion in the group leading to higher lactate levels on the runoff. The outcome, as you know, it's a very small cohort. We had quite high numbers of upgrade to ECLS or LVAD patients in these most likely sicker cohort of Impella patients, and therefore a longer ICU and total hospitalization time. We had a fairly okay survival at 30 days of half of the patients. Now coming to the unloading aspect, when you put an IBP in, as you can imagine, there's nothing going on in chest X-ray. It is just wet. If you put the Impella support in, you see a significant increase via the unloading over time at 24 hours and also at 72 hours. And when you look at the individual cases, I think it's much more apparent that you're really doing something here. As you have seen, it doesn't really translate directly into survival, but what is interesting, when you group the whole cohort into patients that decongest, so meaning that they have a reduction in pulmonary congestion, Halperin score within the first 24 hours, you see that there's a better survival in these guys, clearing up their lungs within the first 24 hours. And if you are in the chance of deciding what type of MCS system you would love to have in yourself, then you could say, well, the chance of decongestion when I use the Impella is somehow 75% or 73%. If you go for an IBP, it's just like throwing a coin. So to sum up my data, it's only a small conclusion, and of course there are tons of limitations. That's why I put some perspectives in this conclusion. Our observational data suggests that early progression of pulmonary edema is associated with poor outcome in cardiogenic shock. Left ventricular unloading by Impella may facilitate pulmonary decongestion in cardiogenic shock. Of course, it's a small sample size and it's in retrospective design, but I've shown you that the Impella patients have been really, really sick. And so I think we can still extract something from our data. And I would love to decipher a role of this pulmonary congestion, because it's really easy. If I ask my assistant doctors in the middle of the night, what's the PC pressure like, what is, let's say, the LV pressure loops, it will be hard to get the real results, but it may be pretty easy to analyze first the outcome and confounders in large registries, and also to do a prospective analysis of pulmonary congestion in cardiogenic shock, because you could easily assess pulmonary congestion by ultrasound, not by chest X-ray. You could try to guide your escalation strategies by these easy applicable methods. You could think of weaning and hemodynamics. Mechanistic studies in large animal models, I'm talking to Denmark here. I'm curious about mitochondrial function, ROS production, and inflammation during unloading. We already talked about that. And Daniel Scheiber of my group is presenting some data, I think, in 2 talks, Daniel. So thank you very much for your attention, and especially for bringing us here.
Good question. Just one caveat, when you talk about the mortality, you had a blanking period, and if I remembered your slide, you had 10 deaths in the IBP arm and 1 in the other. So you already have, you have a survival hurdle to get over that first day, and you lose a lot of the IBP people. But for me, the question isn't about IBP. It's like, when I see the whiteout, do I reach for the Impella, or do I reach for the ECMO? And that, I think, I don't know what the panel thinks, but that, I think, is the bigger dilemma. Can we decongest them fast enough with unloading, or should we just protect the oxygenation and go with ECMO initially?
Yeah.
How do you manage that contemporarily?
Well, that's $1 million question. Usually we start with Impella, actually. So Impella is first in our cath lab, definitely. Of course, it's less invasive. It's easily to insert. It really helps during the procedure itself. So we came across this data that whenever I have somebody where I know that it will be quite complicated, I put in the Impella first and then do the intervention, and I know that during that time I already have done something to the patient, although it may be a 1-hour procedure afterwards.
I have a really very much related question to yours, Jeff, and I've talked with several of you, like especially Mark Anderson, and I talked with Christian Schulte, I don't know where he is, but the issue really is, you've looked at the chest X-ray, but what about the blood gas? Because the issue is that people see a congestion and they see hypoxia and then they pull for ECMO. But what if, the real issue is how quickly can the oxygenation improve? And we know that there's a delay between the resolution of congestion and oxygenation. And Mark had presented a really cool case where he was asked to put an Impella in, if I quote this correctly. He was asked to put an Impella in a patient that was in a motorcycle accident that was congested. He didn't do it. He put an Impella in, and and he had the blood gases and showed that the blood gases improved, like I think it was in 2 or 3 hours. So the question is, in your retrospective analysis, you must, I imagine that you may have also blood gases from in the chart. So that would really.
I hope so. Actually, I hope
that
so.
would really cinch the. That would cinch the, and then you could show the time course because you may have it every 2 hours or whatever. The nurses pull the arterial blood gases, or just the oxygen saturation.
Yeah, I mean, there's definitely a cool hint. We did this in the ECMO cohort, and there we could see that there was some association between PEEP values actually and FeO2. I haven't done that yet in this population here, but I will definitely tell you. Thank you so much.
I think the other analysis that I would also want to see at some point is when we think about congestion, we also think about biventricular congestion. So of the patients with elevated wedge pressures, how many had elevated right heart pressures in the CVP? And the reason why that also becomes relevant is that, the pumps are great for pushing blood around, but if the kidneys aren't seeing perfusion, or if the kidneys themselves are congested and you've got nephrosarca, then the issue then becomes, how are you going to get rid of how are you going to decongest? And so oftentimes, especially in our biventricular cases with Impella or with ECMO, where the next catheter that goes in is a hemodialysis catheter. So can you tell us a little bit about any data on the renal function, and did any of these patients get hemodialysis as an adjunct to help with decongestive therapies?
Oh yeah, I mean in this cohort the kidney function I just quoted the GFR, it was almost invisible. Most likely was not that bad. It was similar in both groups actually. It was running about a GFR at 50. I think the incidence of hemodialysis was about 20% in this cohort, not that high actually. But you are right. We have some values on kidney perfusion on Impella, and to be honest, if you just have a blanking of your Impella console and you don't know whether it's on or not, you could do an ultrasound on your kidney perfusion and you can tell from the kidney perfusion that the Impella is working. You got high diastolic flow rates, and so it is really protective. Actually, thanks for the question. We have a poster here showing that when we compare protected or high-risk PCI, comparing high-risk PCI on ECMO versus high-risk PCI on Impella makes the trick, and we have less acute kidney injury compared to ECMO. I mean, there was a bigger paper, but there was only comparing Impella versus nothing, and we can really show that it's the Impella effect and not the circulative effect.
To fold back to the RP, and we've had a couple of very dramatic cases where patients with the RP have started urinating profusely on the table once you put the device in. I mean, dramatic decongestion.
I think it's worth reiterating what Dan said about hypoxia should not equal ECMO. It underscores a couple of things. One is to truly assess the hemodynamics. Certainly if somebody is profoundly hypoxic with a saturation of 60 and their wedge is 40, it's going to be difficult to turn that around in an hour. But what we found is that the incidence or the need for VA ECMO can certainly be reduced by obtaining hemodynamics and assessing the degree of congestion, number one. Number two, when we get called for that VA ECMO and our strategy is to unload, then we generally reach for the most powerful tool. And if we're involved, certainly we reach for the 5.0 because I want maximal unloading and decongestion in those patients.
In acute myocardial infarction, the experience of the cath lab is that you get patients with severe pulmonary edema and shock in AMI on the cath lab table. You tell the anesthesiologist that he should not intubate yet. You put an Impella CP and you see that the patient says, well, now I'm feeling better, and he doesn't need an intubation and he doesn't need an ECMO. So gaining some time in doing good Impella support often resolves this question on the cath lab table.
I think that's important because sometimes the tendency is to be dramatic and intubate and put them on ECMO because there's so much more action. You feel much more important doing that than a very elegant, simple catheter in the left ventricle.
Okay, thank you very much. I think we go on with the